Okay, can you guys see my screen share progress in the fight against Medicare privatization? Can you see that?
Perfect.
Okay, well, I'm sure you are all aware of direct contracting entities and the effort to privatize traditional Medicare that was started under the Trump administration, but this engendered a whole lot of outrage amongst the progressives and left middle of the roaders when it came to light that people were being put in there without their consent or knowledge. So CMS transitioned the program to the ACO REACH program with a friendlier name. REACH is Realizing Equity, Access, and Community Health. Let's see. So basically, the problem is that the for-profit entities are within the ACO REACH. Basically, it's not traditional Medicare. Traditional Medicare transitioned into the ACO REACH program for lots of people. So who are the for-profits in there? They're the insurance companies. Many of them also have a Medicare Advantage plan. Venture capitalists, capital companies, and private equity investors. Let's see. Okay, so Medicare Advantage started in 2003 under G.W. Bush, and direct contracting entities started in 2021 under Trump. The transition from DCEs to ACO REACH started in January 2003 this year under Biden, and lots of those DCEs that were already recognized were transitioned into the new ACO REACH program. So the CMS goal, and it's stated, is to have all Medicare patients in the Medicare ACO REACH plan by 2030. So as we all know, privatization of Medicare diverts public funds to investors. Traditional Medicare, 98% of funds are go to patient care. Medicare Advantage, 85%, with 15% to overhead and profit and administrative costs. And if you have traditional Medicare, most people have a Medicare supplemental, which you have to buy from for-profit insurance companies. And basically, they use 78% of that money and keep 22% for themselves. And now we've got ACO REACH, which some question about how much they can keep, but it's probably on an average of 25% for profit and administrative, but some people say it can be up to 40%. So here's what we got. Medicare is assigning people to the primary care physicians, ACO REACH. So if your primary care physician is in a group or whatever that contracts with ACO REACH, then you are going to be within that ACO REACH. The only way you can get out of it really is by finding yourself another primary care physician that is not in an ACO REACH program. So Medicare prepays ACO REACH for a range of services on a capitated basis. So the less services a patient gets, the more profitable the ACO REACH becomes, as we all know. And again, the only way to get out is to find a new primary care physician. So without congressional oversight, there's 2.1 million Medicare members, beneficiaries were traditional Medicare beneficiaries were automatically assigned to ACO REACH in the year 2023. So everyone of traditional Medicare was assigned, as I mentioned. And again, they would like, the CMS would like to get everybody within that system by 2030. So there was a public outcry, obviously, that forced Medicare to stop growing REACH. before the outcry transition from direct contracting entities to ACO REACH, but there was a public outcry of people being forced into these Medicare plans, the for-profit Medicare ACO REACH plans. And people were getting pretty sophisticated about what was going on here. And, people all over the country raised an outrage. So ACO REACH was more or less forced to stop adding new entities into the system until the model is reevaluated or evaluated in the year 2026. So right now there's 2.1 million Medicare beneficiaries in these ACO REACH plans. Unfortunately, these plans can also accrue new beneficiaries into those plans that are already going now. If if they keep their primary care provider who was in there. So it's probably going to grow, but I've seen estimates probably not going to grow by more than a million more people. So if Medicare Advantage is so bad, why do people sign up for it? That's a good question. Because, if you're trying to talk to somebody who has a Medicare Advantage plan, a lot of them say, well, I like my plan, it's got really low premiums and it covers stuff that traditional Medicare doesn't cover. So, you have to be very nuanced when you're talking to somebody who has Medicare Advantage and likes it. Basically, it's hard to convince them that if you really need medical care, you're going to really not like Medicare Advantage, and it's going to be hard for you to get it out of it. So let's see. All right. So traditional Medicare does have its problems. So Camilla Jayapal and us, when we talk about Medicare, we're always talking about improved Medicare for all. HR 1976 is Promola's plan. So traditional Medicare now, there's like 20% outpatient co-insurance. There's a $1,600 hospital deductible, and that's for each, I think it's for each time that you have to be hospitalized during a year. And there's no out-of-pocket limits, as there are in Medicare Advantage. There's out-of-pocket limits there up to a certain amount. So there's premiums for Part B that I think what 60, I forget what it is, $60, $70, $80 a month comes out of your Social Security. Part D is the pharmacy benefit, and you've got to find another plan, Part D plan, to get home pharmacy benefits. And if you have a Medigap plan, you got to pay for that. And I think they kind of average about $200 a month for the Medigap plans. So there's three options for people in traditional Medicare. They can keep the traditional Medicare and nothing more, without the Medigap plan, but they're more exposed to bankruptcy if they do have a major illness. They can give up their traditional Medicare and get into a Medicare Advantage plan. But if you have been sick and used, a lot of traditional Medicare benefits, you might have a hard time getting into traditional Medicare. Getting into Medicare Advantage, depending on where you live. So you could add a Medigap to your traditional Medicare, as I said. So again, if it's so bad, why are people signing up for it? So here's a Medigap plan, and this compares to I think this is a real common Medigap plan with Medicare Advantage. It's about $200 a month for the Medigap, and it only averages $18 a month for the Medicare Advantage. There's zero out of pocket after Part B deductible in the Medigap plan. And in the Medicare Advantage, you don't have to pay anything out of pocket until you're combined in-network and out-of-network costs, charges for medical care reach $12,000 and $4,500, or if you're in network, 8,300. So the benefits with a Medigap plan, there's no additional benefits outside of traditional Medicare. The Medicare Advantage includes additional benefits we know about, pharmacy, hearing, vision, dental, gym clubs, etc. So the networks in Medigap plans are identical to traditional Medicare, meaning basically you can just about go anywhere. There's no restricted networks. Whereas in Medicare Advantage, the out-of networks, there you have a limited network, and it may not include the best cancer care hospital in where you happen to live. And if you go see a doctor that's been recommended to you who's not in the system, then you got to figure out how to pay that person. So utilization management is pretty rare and in traditional Medicare. And typically Medicare Advantage has proprietary prior authorization step therapy. You got to jump through a bunch of hoops before you can get your treatments. But the main thing that people see is the average $18 a month Medicare Advantage, that you have to pay Medicare Advantage for all these benefits. But then again, that's for people, like only 20% of people use their medical health insurance every year. So 80% of people are not even going to see that. So again, why it's so bad? So people who are on traditional Medicare, they say, well, if I have to pay more with extra for Medigap, if I get sick, then I'll go into a Medicare Advantage plan. But they won't let me see the doctors I want. So again, so business of Medicare Advantage, here's how they make their money. Frauds, settlements, they make CMS. You've probably seen a bunch of information recently about all the bad actors in Medicare Advantage who defrauded the system. And, I think maybe 10-15% of them are counseled by CMS to, stop doing what they're doing. And some of them, a few of them do pay, large settlements, but many of them just pay some fines, but they don't have to admit guilt. They don't have to admit guilt to pay the fine, they can just pay it. So cherry picking, they advertise to market and bring in people who are generally healthy, that aren't going to deplete their funds. Lemon dropping, again, if somebody uses the system, the Medicare Advantage system, and it costs them more money than they're taking in for that patient, they'll try to figure out how to drop them out of that plan. It's called lemon dropping. And this is one of the major ways they make money, is by upcoding, by making people see a lot sicker than they are. And, we're all familiar, we've seen lots of information about how that goes. So the current status of ACO REACH, again, blowback from progressives, and the CMS response was to limit the pilot programs. Now there's no more going to be added until 2026, until they can evaluate what happened in these 3 years. There's 131,000 plus providers within the system, 2.1 million aligned beneficiaries, and more can be aligned, again, as I said, if the PCC if their PCC is in the ACO REACH. And again, the model is going to be evaluated in 2026. So Medicare is lean, efficient, and effective. There's only 2% overhead, and it's difficult to imagine a healthcare program that's more efficient than traditional Medicare. So this is what we got to do. We got to stop privatization and drive it back. So one plan is to sour the milk for Medicare Advantage, eliminate the Medicare Advantage overpayments if that's possible. And there's, I think Biden introduced some rules or whatever that was supposed to limit the amounts that Medicare Advantage plans could increase each year. The Medicare Trust would pay them and increase, 3% or something each year. Or the Medicare Advantage plans wanted to be, I think, 6 or 7%, but I think it was dropped back to 3 or 6% or something or less. So, and there was a huge outpouring of blowback from the Medicare Advantage plans who had a bunch of ads saying they're taking your Medicare away from you. So write your Congress people and tell them that you got to stop this attempt to limit the yearly increase in the amounts of money that the government is paying us for your care. So it's got some secret rules. So another thing would be to try to get Medicare Advantage to widen their networks to cover pretty much all networks, the same ones that traditional Medicare does. And again, get rid of the bad actors from the program. But I don't know if anybody's been dropped out of that as of yet. But there's a lot of bad actors there, Okay, so another strategy is to, quote, sweeten the juice of traditional Medicare. In other words, make it better, expand the benefits. In particular, people, me, you, everybody is not happy that traditional Medicare doesn't cover hearing, vision, or pharmacy, dentistry, et cetera. So we can work on trying to expand those benefits. We'd like to have a cap on out-of-pocket expenses and ensure equitable access to Medigap. Because if you're in Medicare Advantage and you want to go back into traditional Medicare, the Medigap plans, most of them, except for some parts of the country, don't have to take you, because they'll say, well, this person's leaving Medicare Advantage because they spent a lot of money, and so they don't have to take you. So it's not all that easy to get back. Okay. So we got to stop Medicare Advantage and privatization now. So we need to keep our eye on Medicare to keep its promise of no further growth in the ACO REACH. We'll fight any signs of REACH growing, protect traditional Medicare, foundation of Medicare for all. So our opposition is growing, and it's, our opposition from the private insurance, all the entities and corporations making money off our current system they've got a whole lot of money to fight back. So it's the formidable opposition, but not invincible. So what can we do to stop privatization? Well, we've got opportunities for education, educate people that are being ripped off, and use the data from PNHP, Progressive Caucus, New York Times. There's been a lot in there recently that we can point out to people about the fraudsters and bad actors in there. So people get angry when they hear about this and they want to know what they can do. So direct them to the action steps that fit in with a larger strategic plan. Now here's an ad that PSARA, Puget Sound Advocates for Retirement Action, which is in our Pacific Northwest, Washington, and has been really the leader in the fight back against ACO REACH across the country. And, PNHP Washington knows these folks, and we work closely with them. But they've got more money and more activists than we have. So this is an ad that was in the Seattle Times and several other local newspapers a few months ago, and it was followed up by another ad. But this is talking about how people are getting ripped off, and call these senators and so on, and call these people and tell them you're unhappy with this. And we did hear back from Susan Del Benny's office that they were pissed that they were getting all these calls generated by this tactic. So sign-on letters. I think there was like 130 some organizations that signed on to a letter that PSARA generated, and we helped generate that too, calling on the termination of ACO REACH. So we got a bunch of community leaders and organizations to sign on to that letter that was sent to Biden, CMS, PSARA, and all of our congressional delegation. So build networks. So this is really key, and one of the things that PNHP has for one of the 4 pillars this year is to develop coalitions in your community with other progressive groups that are, have the same goals in mind that we have. And we haven't done that as well as we can in the past, but that's something we really need to do. And call out the privatization schemes, because there's privatization schemes and several other, should be public facilities, the buses and trains and that sort of thing. And the privatization of everything, I think somebody mentioned it earlier this year, definitely a book to read, because it shows how privatization has infiltrated all kinds of things that we really depend on, and for the worse. Like, and now the post office, I hope we can keep the post office public. So draft the national plan that we can get people across the country to buy into, and get people in the different states to work on their congressional delegation. So this is what PSARA has done, research the privatization of Medicare and spread that word around. And a lot of that research has been done by PNHP and other public citizens and other places. So again, educate, have meetings with professional congressional reps and staff. And there's been several meetings with Patty Murray and Maria Cantwell's staff. And in our state, Pramila Jayapal and Adam Smith are the only 2 that have signed on to Pramila's HR 1976. So we need to work on them. So PSARA has a very active, good website. They send out frequent email blasts at least a couple times a week about actions that you can take, or meetings and stuff coming up. Sign on letters, resolutions, and there have been several resolutions. The Seattle City Council, the Washington State Democratic Party have signed on to basically the anti-privatization resolutions. And there's a whole lot of resolutions. I forget how, at least 20 organizations in Washington State have signed on to that. And there's information there on how to lean on your congressional delegation. Almost finished. So again, protect and strengthen traditional Medicare, campaign strategy, build a sound foundation for improved Medicare for all. And we need to end Medicare privatization and all its forms, and also to protect Social Security. People are really concerned about Social Security. So that was the strategy, the tactics: terminate the ACO REACH pilot program as soon as we can. Looks like we won't be able to do that for at least a couple of years with the current Congress, and CMS isn't going to really evaluate the programs for another 3 years. So PSARA would love to see President Biden end this, which he could do by executive order, but there's no way he's going to do that, because as you remember, he says he would not sign a Medicare for all bill. So again, there's no further expansion of participants. Pilot will end. Expose and educate people, policymakers, and the wider public about Medicare Advantage plans ripping you off, blah, blah, blah. Fleecing the Medicare trust and taxpayers. And you're always hearing about how the Medicare trust is going to go bust, but probably won't if we can stop some of this stuff. And, these insurance companies delay and deny critical care to seniors, and there's whole lot of statistics out there about that we need to spread around. So we'd also, again, like to allow traditional Medicare to offer the same level of benefits to beneficiaries of Medicare Advantage plans, allowed to offer all these things on the left here. Allow Medicare beneficiaries to move from Medicare Advantage plans to traditional Medicare plans without, we need guaranteed issue that these supplement plans are going to have to take you. And here's one that would be pretty hard to get: require those private insurance companies to pay back the money that they ripped off from the Medicare trust over the years with interest, and make restitution to Medicare beneficiaries who got their care delayed or denied and suffered the consequences. Remove fraudulent bad actors and support Ro-Khanna's bill that we talked about earlier. And also, we don't want those Medicare Advantage plans to be using the term Medicare because it's too confusing to most people. So they should be called alternate private health plans. And so we don't want them to, gobble up the word Medicare, which generally people have a good feeling about, and don't use it in their advertisements and so on. Okay, that's it. Let's see if I can get out of this somehow. Okay, are we back?
Yep. Thanks a lot, David. Chuck, you want to continue?
Mike, I'm not sure that Chuck can see raised hands on his screen.
Okay.
Can you, Chuck?
Yeah, I'm back here. Yeah, Sam and then Lynn have raised hands. So Sam, Lynn.
Thank you, Dave. Thank you for your presentation. Mike, is there a way you can make these slides available to the rest of us? Dave, you had some very powerful slides in there, especially about the administrative costs of various programs. I want to commiserate the difficulty in telling people with Medicare Advantage plans that they shouldn't like it. An approach to consider is to say, you may or may not like your Medicare Advantage plan as a patient, but you certainly don't like it as a taxpayer. As long as we keep moving people from traditional Medicare into either ACA, REACH, or Medicare Advantage, the US government will overpay for all of the benefits, somewhere around 15%. So even if you in particular are comfortable with your Medicare Advantage plan, you in particular, as a responsible taxpayer, should prevent your taxes from going up by stopping ACA or REACH, a suggested approach for you.
Well, this is a big topic of conversation with PSARA and PNHP Washington about, we got to be nuanced, and you can't attack people for, having what for them is a good deal at that point in time. So, there's things that you can point out, and, what you just said is like one of them.
Great. Thanks, Sam. Thanks, Dave. Lynn, question, comment?
Yeah, on the pie chart for the supplemental, you have 22% does not go to patients. Is that right?
Right.
So
right,
where
Medicare plans.
does that affect, like I have traditional Medicare and supplemental, and I actually had a bill from Stanford Hospital last year of $315,000, and Medicare and the supplemental paid. I didn't owe a penny to Stanford. So the 22%. So how does that figure? Does that affect the patients?
That 22% is what they keep for their profits and overhead, and they're supposed to spend 70 odd on direct care. But
So they could have lower premiums if they didn't do that.
if they didn't have the 15% or whatever it is for overhead and profits. But those supplemental plans are all for-profit plans, pretty much all of them.
Yeah, I've heard some people have to pay co-pays in a supplemental. I've never had to pay a copay.
Yeah, some of them don't. I think most of them don't, but
Mutual of Omaha is great. Has the lowest premium.
A good advert to slip in there, Lynn. Thanks. Mutual of Omaha's Wild Kingdom. This is what comes to mind. Like,
Mary Alice Bisbee has her hand up, Chuck.
hey, Mary Alice, can you unmute?
Yes. Hi, I don't have a little thingamajig thing to put up, so for
Right.
my hand.
Hold
So
up
I had
your torch. Hold up your
hand.
torch.
I put my real hand up. I wanted to comment on the previous speaker because I'm in Vermont and we have probably one of the only ACOs. It's called One Care Vermont. And the whole state has to pay into the UVM Medical Center, which is a nonprofit hospital. And it now has its own Medicare Advantage plan together with an insurance company with, I forget which one it is, MVP. And I have had for a long time, I'm quite poor. I live in subsidized housing, and I don't have anybody paying for my supplemental plan, which I pay $244 a month for through United Healthcare. And I just wanted to ask, is there a difference between the fact that I use an ACO plan? I don't think they can sign me off to a Wall Street investor, but I think they are. There's so many administrators in the middle taking all the money that we don't have any doctors or nurses here in our state. So I just wanted to put that out there as some kind, if you have any answers for this kind of a thing. Maybe that's different from Oregon and Washington.
well, they've got tons of money and experts to look at their business and figure out how to, make profits. So we're never going to win until we, take for-profit completely out of Medicare, like, Pramila Jayapal's bill would do.
Yeah.
I'm on board. I just wanted, I just got a letter saying that my fee for this year is going up in June to $251 a month. And it does say it's a Plan J that I've been grandfathered in, and I don't have to pay any deductibles or copays at the hospital or even at the beginning of the year for my Plan B.
Yeah, that's the trouble. There's so many different plans and they're all a little bit different, and it's really hard. And then you pay a broker to help you get a plan, and the broker jacks you for about 20 or 30%. And it's not just a one time. As long as you stay in that plan, they keep getting every year a certain amount of money that you're putting into it.
Yeah. Thanks, Mary Alice. And having gotten recent medical care in Oregon, we also have the phenomenon of surprise bills.
We do too.
They account for about 20% of all bills or surprise bills. Hello? I'm clear, right? No. Anyway, don't want to get too sidetracked there. Sherry Lambert, you're up.
I was going to say we're lucky in Washington State that our governor does support universal health care. But I find it a lot of fun to talk to people, especially people that are turning 64, 65, and they start getting all that mail. And because I've gone to a lot of your talks, I've learned an awful lot. And it's just fun to talk to them and educate them. And I always refer to them to PNHP because there's such great resources there, and PSARA. But people they don't know this is happening. And I can relate to them because I'm in an Advantage plan, and I would love to switch now because I'm older and things start falling apart with us. But it's impossible to do it now, pretty much, as I
There's so
understand. But it's
there's
just
so
fun
many-
to talk to people about this.
There's so many ads out there that are deceptive, that you're getting
Yeah.
a million ads, see them on TV, call this number. And if, it doesn't even mention that it's a Medicare Advantage or for-profit plan. It's to say, well, Social Security owes you $200 or something, call this number and you can get it. But then you give them your number and you keep getting these calls from brokers. I did that, and I got at least 10 broker calls before I finally figured out how to stop it.
How did you stop it, Dave?
Oh, I went online and Googled, how do you stop this? And,
Oh.
somehow I did.
Yeah.
Google is amazing.
Right. Thanks for the question, Sherry. The response, Dave. Appreciate that. Yeah. So where do we go from here, Dave? I mean, how do we act collectively to push back? I mean, you mentioned the Mark Ro Khanna bill, Save Medicare legislation, which is designed to strip Medicare Advantage of simply having the frame, the brand. How is it even conceivable that they are able to use a public entity like Medicare and then in their privatized marketing and branding? I mean, that's just astonishing in and of itself. But what does the future hold? What do we need to do?
I think Bernie Sanders is trying to prevent them from using the word Medicare. And, the last 7 slides, I think, in the slideshow were things that we can do now to, fight this. And I should say that some of these slides are from Ed Weisbart from PNHP. He's on the national board and just an amazing guy who puts talks together and does slideshows. He's got, 10 different variations of slides. Those he's put out in the last year or two. So I use some of his slides and then, change them for Washington State.
Right. So, I mean, Sam asked about getting the slide deck. Is it how can other folks get those materials?
Well, I could definitely give you the slides.
Okay. Maybe
Okay.
hand them off to Mike Huntington and maybe the group assembled tonight. Mike, maybe we can send it to these folks who made the effort to get here tonight. That'd be great. I see.
Well,
Looks
I sent it to myself in email, so it looks like it could be emailed. So I'll send them to Mike. And if that doesn't work, I'll put them on Dropbox that Mike can download them.
Right. So a guy by the name of Mike Huntington's hand is up. Who's Mike Huntington?
Yeah. I have seen a comparison of lifetime costs for individuals on Medicare Advantage versus traditional Medicare. And the costs tend to even out over a lifetime. Has anybody seen that information or can guide us to it? Because it looks like it's a really good deal, $18 a month. But if you look at the copays, the pre-authorizations, the delays, getting out of a network and surprise bills, it ends up that they do not save any money.
Well, I think there's a lot of studies that, are close one way or the other, but most of them say that Medicare Advantage is more costly and doesn't provide better health care.
Mary Alice, your hand is up.
Yes, I just wanted to ask another question. Do you, I don't know, my mind is going now. I wanted to ask about, forget it. I'm sorry. I'm getting too old.
No, by the way, your mind is not the only one that's slipping. So it doesn't, I don't think it's even a question of age. It's mind boggling what we're having to deal with. So we're empathetic. I wouldn't be hard on yourself. Dave Garibaldi, our Italian unionist.
There you go. Yeah, I just wanted to mention that here in Minnesota this year, we do have a trifecta. We have, for the first time in quite some time, we won back the Senate for the Democrats. And we've introduced a number of pretty good building block bills, but one of them is it's legislation to prevent companies who sell supplemental Medicare insurance, Medigap insurance, from discriminating for pre-existing conditions. So that would, of course, undo this need for underwriting that we were talking about here, and you'd be able to go back from Medicare Advantage plan into a Medigap plan and traditional Medicare. Now, I actually testified for this, but I did mention the caveat that we could have an influx of people into Medicare Advantage, which would be very bad. And I also see this as when we are talking about lowering the age of Medicare down to 60 or 65, that would be another place where I would see just a massive amount of people rushing into Medicare Advantage. So I'm really torn on this, and I wondered if any of you have any insight in this or what you think of it.
Well, it sounds like a good idea, and I think there's like 6 or 7 states that have a guaranteed issue and local and related to the local costs in their state or neighborhood. But we're still working towards our North Star, which is improved Medicare for all, where there's nobody between the doctor and the patient.
Do you see a danger, though, in having that ability? Because that was a disincentive, at least somewhat, for people to not take Medicare Advantage. But if you get rid of that, all of a sudden that's dried up, and you just say, well, I'll take that $18 a month plan until I really need something better, and then I'll jump back into the traditional.
I mean, good point, Dave. I mean, it's the bait and switch argument nonstop. And this is what's going to come at us from Madison Avenue, from Wall Street. They're going to just continue to cook the books. They're going to continue to gaslight us. And this is kind of, this is really where we are at this point. That's why we continue at one payer states to push up as fast and furious as we possibly can to model a universal healthcare as close to a single payer system at the state level as possible, so we can show the rest of the world, we can show the rest of the states that not only can it be done, it's being done, and here's the model. Here's what we can accomplish. So that's my sort of hope. I call it my radical hope. So my organizing mantra is radical hospitality, which is keeping an open mind, listening, welcoming without judgment. Radical hope, which is more than just hope. It's actually going all in and believing that what we're doing based on our vision is going to get us there. And then radical love, which is continually being empathetic and not losing our sensitivity to our humanity. That's how I think we continue to build these relationships and continue forward. So not to be despondent, not to be unrealistic about what's coming at us. I feel like we're actually in a pivotal point right now, where we're in the middle of a revolution. The question is, which way is it going to go, right? So thanks, Dave, for your thoughts. Pat Chadwick. Great to
Hi.
see you.
Yeah, a friend of mine in Vermont did a very detailed analysis of the whole Medicare Advantage, and I mean, his conclusion was to not use any of the gap plans, which I'm doing right now at my own risk, I guess. But anyway, I can send I mean, it was kind of difficult to understand his paper, so maybe I'm wondering if somebody else in this group might be able to. I mean, I can send it to Mike and he can send it out, but you know, to look at his argument and maybe see if they can understand it better than I could.
Is
But,
this David Belk?
I think he mentions David Belk, but this is written by, his name is Rick Daniels. And I don't think he's somebody that's been an advocate in the field. He just was doing this for his own research. But yeah, he does reference David Belk in the paper. So I'll send it to Mike and then he can send it to the group.
Okay. Thanks. Thanks, Pat. All right. Any other thoughts tonight?
Well, we usually, Mary Alice, but we usually end with an ask. So, you know, figure out
Well,
what that.
Out of what my question was, does anyone here belong to the League of Women Voters? We're trying to get them to come along and help us to speak out as an organization. I'm a member of PNHP. I follow One Care States. I work with Betty Keller, and Marvin Malik has done some presentations here in Vermont that are very helpful. It's very similar to what Dave just did. And I think we're going places, but I can't speak out as a League of Women Voters member nationally or statewide. So if you know anybody that has some help with the League of Women Voters nationally, please let them know.
Repeat your request. Have the National League of Women Voters do what exactly?
They have to approve when anybody in the state, in our state League of Women Voters Healthcare Committee, who have been educating Vermonters,
Right.
but we can't advocate for any change. But if we do it with PNHP, they can advocate while we educate, if you know what I mean, in the state. But we can't do anything with our delegation even, and our delegation is Sanders and you know, we have 3 good delegates in Congress that we can advocate for, but we're not supposed to do it. We can only do it as individuals. I do it as an individual. I sign letters, I write letters, I, send emails, whatever. But it's very hard when the National League doesn't feel it's a priority.
Be wary of AARP, because that's a huge insurance company. That's where like 80% of their budget comes from. United Healthcare,
I know.
Medicare Advantage plans they sell.
Right. Yeah. So thank you, Mary Alice. Mike, let's hear your ask. And Lynn, your hand is up. I missed you.
My understanding with the League of Women Voters is they can support causes, but they can't advocate for candidates, political candidates. It's a nonpartisan. But here in California, they support a whole bunch of issues. It's the National League of Women Voters do not support single payer, and Betty's organization, many of them are pushing to get the National League of Women Voters to support single payer.
Okay. All right. Yeah. Thanks for that clarification. The distinction between issues and candidates. I mean, One Pair of States is nonpartisan as well. So Mike, what our ask for tonight? We want folks to pile on with Sabuca, right? I mean, this is where we're headed right now. we need to get as many people as possible in as many states and congressional districts as possible to contact their members of the House and Senate, educate them up as to what the possibilities are, not just in Oregon and Washington, but also in many other states to model a solution. And again, this has been the pathway to change in US history. This is our history. And in terms of healthcare, it is the history of Canada. That's how they got there. In 1965, when we passed Medicare and Medicaid, just about every single member of Congress in support of that said, just be patient, be patient. We're going to get to universal healthcare in the next few years. Well, you know, a little tiny thing called the Vietnam War sort of intervened, and that went sideways. Johnson was defeated by Nixon. Nixon cut a deal with Kennedy, and then we got sidetracked, you know, with HMOs and the rest of the history we know. But we need to be intentional. We need to be focused, and we need to see the prospect, not only the possibility, but in my mind, the probability that we get this accomplished at the state level. And we just have to pile on as much as possible and not be distracted by the noise and the negativity of folks who just don't see it. You know, just stay focused on who we are, what we are, and understand that we've got the momentum, we've got the tools, we've got the mechanism for getting this done at the state level. We just simply have to do it. So I'll be in Washington, D.C. Folks, contact me if you have questions at all whatsoever. I'll happily carry you on my phone into your member of Congress and say, this is Mary Alice Bisbee. I'm in Senator Welch's office. She wants to talk to you, and she wants you to sign on with the Senate bill, the Senate companion bill for state-based universal health care. That's what we need to do. That's what we need to get accomplished. So I'm actually very excited about this opportunity where we are right now. Thank you. Mike, do you want to add anything?
Yeah, the other is please send donations to One Pair State so we continue wonderful programs like this. I also want to let you know what's going to be available as soon as we figure out the right timing. It's a one-click politics campaign. This is what it would look like. We can change out Walter Cronkite with someone that younger people might recognize if you wish. But basically, this goes to the target constituency of who we choose, and that could be the committee that decides on this Sabuka bill. It could be in the entire Congress. We can target whoever we want, and this explains to the constituent why we're concerned about state-based universal health care. And then once they put in their information, like this will show you, and my case, it will go to our two senators and our representative for my district, and this is the message that they will receive. That talks about why we're in such a bad situation with our healthcare, a little bit why we think state-based universal healthcare will help us get to a much better place. Please honor states' rights to create their universal healthcare systems by passing the State-Based Universal Healthcare Act when Ro Khanna reintroduces it in the 2023. Then you submit. So please be on the lookout for that as soon as we decide the right timing and maybe edited wording.
Terrific. Yeah, it's a great software platform for lobbying. So thanks so much for that. Appreciate it. All right. Let's just close out for this evening. Anybody else have a final comment? Dave Mclanahan, thank you so much. You did a great job. Bravo, bravo. Seattle's best.
You too, Chuck. You too, Chuck. You too, Chuck. Yeah.
All right. Me too. Right. Thank you. And for everybody's questions and comments, your engagement, really love your energy, your passion, always stay positive. It's not easy. We know this, especially when we see Donald Trump rising in the polls, right? So it's okay. We're going to get through this. We're going to win. We are going to prevail.
Lodi has her hand up.
Lodi.
Yes, I have a question, Chuck. How long will you be in DC or at the Capitol? If we can, I'm thinking we have our State of Georgia Legislative Task Force meeting tomorrow. So if we can get a couple of our organizers to give you a call while you're there so we can reach into our representatives so we can do exactly what you just said.
Yeah. Well, I'll know more on Thursday when we meet with Emma Preston, who
Okay.
is Representative O'Connor's healthcare legislative aide. I'll know about my timing, but I'm probably going to head over to the DC area from where I am in Pittsburgh right now, around say April 25th. Is that?
Okay. Yeah, that works. That's perfect. So again, with Georgia, you know, our governor is anti-universal health care. He has his own healthcare system, no Medicaid for all, just a total uphill battle, but it can be broken. I am optimistic about that.
Yeah. And I mean,
Because
and
it's
the
not
work
what
I'm
the
doing.
people want.
Yeah, and of course, again, remember the work we're doing together at Center for Common Ground with Andrew Miller. So that's a great connector. Get me if you could get me your personal contact information and vice versa, and let's stay in touch.
Yes, sir. Thank
Okay.
you.
I'll drop mine in the chat. I'm an open book. I just write it on bathroom walls anyway. So it's all, I'm open source. But thank you, everyone. Just hang on, Lode. I'll just drop that in there real quick, and everybody knows how to reach me by text. This is Chuck at 215-828-5055. So I will be in the Capitol for late April into May, and don't hesitate to reach out to me via text, phone, and then let's hammer on your state reps and your senators to get them signed up. There we go. Everybody have a great rest of your evening. Thank you so much.
All right.